I'm Samantha Wood. I'm one of the attendings at Downstate. For anyone who doesn't know me, I'm going to present a few cases on endocrine emergencies. It's a little bit interactive. The questions I have in the talk are very simple. So if you just try to participate, that would be super appreciated. It is slightly Pokemon themed. Um, all right, so I'm going to talk about three uncommon but important endocrine emergencies. We'll discuss their management and then any pearls or pitfalls. So the first case, all of my cases are based on actual cases I had. Some of it I had to like remember. So this was a 52-year-old woman with diabetes, asthma, schizophrenia. She had a recent admission at an outside hospital for what sounded like an asthma exacerbation and psychosis. She came with confusion, vomiting, and weakness for about a few days. You can see that she was febrile, tachycardic. She was a little hypotensive, a little hypoxic. We noted on exam she really couldn't give us any history. She had an incomprehensible speech, crackles at her lung bases. She had diffuse abdominal tenderness. Cranial nerves were grossly intact. Her pupils were equal and reactive, and she was moving all of her extremities equally. So, does anyone want to throw out a differential for this? Sepsis, DKA, yeah. And so like it's an endocrine tox, so thyroid storm. I thought about like overdose. She has like this unclear schizophrenia history. Maybe PE. We've been seeing a lot of PEs lately. So for the interns, what would you do? How would you help her? The usual IVO2 monitor. What else? Antibiotics, fluids. Okay, so you do all that and she's worse. You've made her worse. So what would you do now? She's a little hypoglycemic. So you give her some dextrose. What would anyone do now? Throw it off. Give her, well, she got 3 liters. Yeah. We got Prezzers and steroids. Okay. So I put out do a rush first. What are we dealing with? Her rush was normal. Her IVC is full now. She has no pericardial effusion, no aorta pathology. Just some like B lines on pulmonary exam. I heard a call for both pressors, which we started. She's still not doing great on like 17 of levo. And then there was a call for steroids. Why do we give steroids? So if you have like relative adrenal insufficiency or potentially adrenal crisis, steroids may be beneficial. Does anyone know what the preferred steroid is? Hydrocortisone. Do you know why? Yeah, it has both mineral. I heard someone mumble mineralocorticoid. It has both mineralocorticoid and hydro glucocorticoid effects. Um, so typically we're giving this in the ER if a patient's on chronic steroids and now they have an acute illness. They might have relative adrenal insufficiency, so they don't have enough adrenal cortisol to meet the demands of their new infection or new insult. Or patients who, for whatever reason, were abruptly stopped on steroids. So we were thinking that maybe this patient had been on steroids while she was hospitalized and then wasn't really tapered down or didn't reliably take them. Um, and then, as mentioned before, hydrocortisone is preferred agent. Does anyone know why you might give another steroid? Yeah, you can like in theory you can give dexamethasone, which doesn't have an effect on the cortisol levels. That will like help preserve their cortisol levels in order to do a more accurate ACTH stimulation test. In practice, like I was talking to my friend who's like a ICU pulm critical care doc, and she was like, I don't really think there's a whole lot of benefit to doing that. So I typically would recommend doing hydrocortisone. It's important to note there hasn't been a definitive mortality benefit shown in doing this, but there has been overall benefit in terms of like length of ICU stay, resolution of shock. So still a good agent to give. And then no one mentioned vasopressin, or if they did, I missed it. But then why do we give vasopressin? kind of have it there, but. Yeah, it's like an adjunct agent, helps maybe in severe shock situations. In theory, the benefit is that it's reducing your overall pressor needs, which the studies I've seen, uh, the best benefit they saw is that it less likely to have a atrial fibrillation. You can maybe extrapolate that maybe less likely to have other arrhythmias or like ischemia of their limbs. I don't know if any of you have been in the ICU and had patients who were getting limb ischemia from being on pressors for a really long time, but it's not ideal. Um, so you do that, you give her hydrocortisone, you start her on vasopressin along with Levophed, and she gets better. Does this patient meet the criteria for adrenal crisis? Some say yes. I mean, it's tough because adrenal crisis doesn't really have a great formal definition. There's like variably defined in the literature, but the best sort of all-encompassing points for adrenal crisis are confusion, altered mental status, hypotension, and patients often complain of like abdominal pain or chest pain um, in studies that have been done. I will also note that in the emergency department, it's probably not that important for us to try to distinguish between like a severe relative adrenal insufficiency due to some other cause versus adrenal crisis due to just problems with the adrenal organs themselves, because we're not going to be able to figure that out. So, and the treatment is the same. There was one paper I looked at that going to this, and I'll go back to the other one, that showed a proposed criteria for adrenal crisis. And that includes confusion, fever, as you mentioned before, vomiting, and then some other lab abnormalities. So hyperkalemia is more associated with just primary adrenal insufficiency because there's a decrease in mineralocorticoid levels. Whereas hypoglycemia and hyponatremia can occur in both primary and secondary or tertiary causes of adrenal insufficiency. So you're more often likely to see hyponatremia and hypoglycemia in these patients. So our patient had just a very mild hyponatremia, normal potassium, still like a persistently low glucose. So she was given extra dextrose and like a slight AKI. Her abdominal CT just showed a nonspecific colitis pattern. She was admitted to the MICU and did okay over a couple of weeks. Okay, so now just to briefly go over the different types of adrenal insufficiency. Primary adrenal insufficiency in the US or like developed countries, that's most likely due to Addison's disease. Does anyone know some other types of primary adrenal insufficiency that, I don't know, I feel like in our patient population, you could theoretically see it. TB. Yeah, so like tuberculosis, the other infectious cause would be like HIV, AIDS, and then very rarely like Waterhouse-Friderichsen syndrome due to meningococcemia. More often in the ER, we're seeing central causes of adrenal insufficiency. That's usually just due to them being on chronic steroids for so long that they have now had adrenal atrophy or they have abrupt withdrawal from their chronic steroids. Other causes of central adrenal insufficiency to at least know about are like pituitary tumors or very rarely like a hypothalamic tumor could cause it. But I've never seen that. Okay, so in general, anything that can stress you out can lead to adrenal insufficiency and adrenal crisis. Again, the most common indication that we're seeing in the ER is people who are like are on insufficient steroids or have had their steroids stopped for whatever reason. And then just a note on adrenal insufficiency testing. I know we kind of like mentioned it earlier. Um, I don't think there's a point if your patient's on chronic steroids or supposed to be on chronic steroids. I don't think there's a lot of point in doing any sort of testing from the ER. It's not going to be reliable. It's often not reliable in the setting of critical illness anyway. But if you had this rare patient who you thought was maybe in adrenal crisis due to something not related to steroids at all, you could send a random cortisol level and a random ACTH level for the inpatient team to follow. And in that case, if the random cortisol level was under 500, that should prompt consideration for doing an ACTH stimulation test once the patient is stabilized. So basically, it would have to be like on steroids for a while, doing well, and then they would hold the steroids and then administer an ACTH stimulation test. Um, I don't think I've ever actually seen it done, but that would be like the rare case scenario where it might be of benefit. Um, okay, so consider adrenal crisis in patients who have refractory hypotension despite high dose pressors, patients who are on chronic steroids of a critical illness, patients who have hyponatremia and or hyperkalemia, or patients who have unexplained or persistent hypoglycemia. Hydrocortisone is the first line steroid to give. And in rare cases, you can send a random cortisol and ACTH level from the ER for the inpatient team to follow. Okay, so second case. So this case I had in residency. It's a 62-year-old female. She had a history of thyroid disease. That's all they kind of knew about her. She was brought in by EMS after she was found down in her apartment. No one really knew how long she'd been down for, maybe a couple days. EMS told us that her apartment, like living conditions were terrible, that she looked like a hoarder. Like there was like, it was just like very, very dirty. And the patient like herself couldn't answer any questions. She was like very sleepy, couldn't really say anything to us at all. She was noted to be hypothermic, bradycardic. Blood pressure was okay. SAT was just a tiny bit low, and her respiratory rate was a little bit low. Um, on exam, she could like open her eyes in response to noxious stimuli, and she could like move her extremities in response to noxious stimuli. She appeared very edematous. Like her like legs were, she had like a lot of lower extremity edema. Her whole body was kind of just like puffy. She had some coarse breath sounds on lung exam, but no abdominal tenderness. Okay, so differential for that. Mixed edema coma. Yeah, I know. It's like not even that hard. I mean, but I mean, she could have other things. uh, So, so like it's always, I mean, you have to like think about like why did she go into mixed edema coma? And a lot of the patients, like I had like those two hypothermic patients back to back that were both not mixed edema coma, and I was like, when will I ever see this again? Um, but they were just septic. So like consider just septic. So consider just giving empiric antibiotics to these patients because a lot of times there's some underlying cause that brought them into that state, and you want to cover early. And then she could have had a head bleed. You know, as Riddy can attest to, people can have more than one thing, like a head bleed and sepsis and like something else and a PE. Yeah. And then, you know, it was springtime when this happened, so we weren't really thinking environmental hypothermia. She was in her home. It wasn't that cold. Um, and then mixed edema coma, I guess nowadays people say the better term for it is decompensated hypothyroidism because it emphasizes more on the organ pathology and not their like mental state as much. Like not every patient you see is going to be in a coma. And rhabdo, she was on the ground for a while. Okay, so how would you manage this patient other than the sepsis part? What did you say? Steroids. I mean, you know the theme of this talk, yeah. But what, how would you treat like her her vital sign abnormalities? How would you warm her? Bear hugger? Yeah, so you don't want to warm too aggressively, but a bear hugger is okay. Warm IV fluids. I learned this recently that warm IV fluids don't really warm the core temperature that well. They just prevent it from dropping further because it dissipates so rapidly into their cold bodies. But at least it doesn't make it worse. So if you can warm the fluids, that's good. Bear hugger, um, steroids, you got to call for steroids. Nothing wrong with some steroids in these patients. Um, You can send labs, obviously, empiric antibiotics, as we mentioned before. And then we got a head CT. It was negative. Chest X-ray just showed pulmonary congestion. And then these were her initial labs. So she was very hyponatremic, normal glucose. She had like some slight AST, ALT elevation, an AKI, and I didn't have her thyroid studies back. So in residency, you know, many, many years ago, it took hours, sometimes like almost an entire day at first to get thyroid studies back. So it was really like hard with this patient because we were like suspecting this is probably myxedema coma. And we kind of felt like we didn't really have a way of proving it up front. We did give the steroids and we were like kind of torn, like, at what point should we be getting endocrinology involved? How long am I going to wait on this test? Nowadays, I feel like most labs turn thyroid levels out within a few hours at most. Like it's not so bad. I don't know if any of you will end up working in like maybe more like a critical access hospital where this might not be the case. Um, but either way, there are some like helpful strategies in terms of deciding, whether this is somebody I want to empirically treat for hypothyroidism. So in decompensated hypothyroidism, I like to think of it as like everything is low or most things are low. You have like low vital signs, low mental state. They may not be like completely comatose, but maybe they're sleepy or confused or like more forgetful. There can rarely be seen what's called like myxedema psychosis, where they actually are like floridly psychotic, but I've never seen it. My friend has seen it once. It's overall a very rare condition. And then the other thing that's low can be like hyponatremia, hypoglycemia, as we saw before. Okay, has a very high mortality, which is why it's important to consider the diagnosis and even empirically treating these patients, because even with treatment, there can be still a very high mortality. Okay, so there was a recent study that compared 21 patients who had like a known diagnosis of myxedema coma or decompensated hypothyroidism, divide like a scoring tool based on that. So it's not like a robust patient size, but I found it pretty helpful just like looking through and thinking, did it correlate with my patient and how we treated my patient in the past? If the score is greater than 60, it's very suggestive of decompensated hypothyroidism. If the score is under 25, then decompensated hypothyroidism is unlikely. Um, our patient had a score of 80, so she was quite high. Um, so since you would get the labs back faster nowadays, let's just like briefly go over what the labs would look like. Typically, most of our patients who have decompensated hypothyroidism or hypothyroidism in general have primary hypothyroidism, so they'll have a very high TSH and a very low free T4. If it's the rare like central hypothyroidism, they'll have a low to normal TSH, and then they'll still have a very low free T4. You can send a cortisol to evaluate for possible associated renal insufficiency. It tends to be low to normal. So our patient had a very high TSH, very low free T4, and then a normal cortisol. One other note about the labs, like don't just anchor on like the lab values themselves or like the absolute lab values, like also take into consideration um either if they have signs of organ failure. Because people can have like abnormally like severe hypothyroidism, but still be compensating. So you want to look to see if they have signs of like failure in terms of like their brain function, so they're having confusion or sleepiness. They have like a renal failure, respiratory failure, or like cardiac abnormalities like bradycardia or congestive heart failure. Okay, and then on to treatment. So hydrocortisone was mentioned early. Always a good move in these patients. That's to help if there is an associated renal insufficiency. It doesn't really have a downside. The only other thing to note with it is that it should be given concurrently or before giving any thyroid agent, especially T3, which we'll talk about later. But and because if you don't give it up front and there is adrenal insufficiency, you can precipitate adrenal crisis. The good news is that T4 or levothyroxine is the inactive form of thyroid hormone, so it takes hours to have an effect anyway. It's very safe to give, and from what I can tell, in my experience, like talking to endocrinology in the past, you can give it even almost empirically, like before you even have all of your thyroid studies back. So in this case with my patient, they ended up just giving T4 alone. And in terms of the dosing, the lower end of the dosing range is preferable for patients who are elderly or at higher risk for arrhythmia. And then I guess you can consider giving the higher end if you have a very sick patient. I've actually never seen endocrinology give T3 like ever. Um, the concern is that there is a associated higher risk of arrhythmia and potentially increased mortality with it. But it was a pretty like small study that looked into this, and then it was kind of based on giving like a really, really, really high dose of T3, which we don't even give anymore. But still, I never see endocrinology give it. It's almost like it's not necessary for the vast majority of cases. So I think I would just talk to endocrinology about it and only consider giving it if you have a patient who's like in shock on pressors or intubated. So like the very, very, very sickest end of a decompensated hypothyroidism patient. Oops. So yeah, so she got hydrocortisone, T4, and then went to the MICU and eventually did okay. Although I never found out about her housing situation after that. Um, Okay, so pros and pitfalls. Remember to send TSH, free T4, and cortisol level from the ER. Consider the diagnosis even empirically on patients who have signs of low vital signs or confusion. Hydrocortisone and T4 can be given safely. And endocrine consult for further recommendations and need for T3 at all. Okay, last case. Um, So this case I had, it was like my first year at MIMO, actually. And it was like just a very, very strange case to me. So this patient, I was working on the critical care side, and this patient was on the main, and the attending had been like managing her and had gotten like two repeat like very abnormal blood gases before she decided to upgrade her because she was like not her vital signs were so abnormal. But I was just like so shocked at the time. I'm like, how would you hold on to this patient who's like, a little hypotensive? But if you met the patient, you would see why. So she was 65. She has a history of hypertension, diabetes. She's on metformin. Her only complaint was like nausea, vomiting, diarrhea for a few days, and some weakness. Her initial vital signs, I believe, were normal, but then she was upgraded to my side when she started to become hypotensive, 84 or 52. But the patient, like if you saw her, you would think she was totally fine. She was like alert, awake, said nothing was wrong, was not worried about anything, just seemed maybe a little bit dehydrated. She had no focal neuro deficits. But then the thing that was like really bad was that she had like this very bad blood gas. And they had repeated it. They had like kept her for like 4 hours, given her some fluids, and then repeated it, and it was still exactly the same. And so when I saw this blood gas, I was like, what is wrong with this patient? Like this is like a really high lactate, and she's so acidemic. Um, so what did you guys think as a differential? You were like, yeah, you already know this. Okay, good. Yeah, but I was so shocked because I'd never seen it before. And so I came up with like, an initial differential. I asked myself, what else can cause a lactate this high? I was like, she didn't have a seizure. She wasn't like poisoned. She doesn't look like severely in shock. She's like mentating fine. So I was only left with metformin associated lactic acidosis. Um, and so this is a very rare condition. Um, there's really only like two main types to know about. So you either have like mala or you have like acute metformin overdose, or like some places call it mila, but it's like metformin associated toxicity from an acute overdose. And the treatment is relatively similar in either cases. I think part of the reason why mala is a little hard is because no one really fully understands how metformin works. It's thought that mala occurs because metformin promotes the conversion of glucose to lactate, and then that also decreases hepatic gluconeogenesis from lactate. So when a person already has some sort of acute illness and then they're on metformin, that can lead to like an increasingly severe lactic acidosis over time. I've only seen mala in patients who have already pre-existing comorbidities, so like liver failure, heart failure, or some degree of like kidney disease that's been worsening over time. And for some reason, they haven't been stopped on their metformin. It does have a high mortality. And it's important to note that the initial pH and lactate values may not predict mortality in the patients who are having mala. who are chronically on metformin. pH and lactate may have a predictive value in patients who have an acute like metformin overdose. They actually did a retrospective study of emergency department patients with suspected sepsis-induced lactic acidosis, and they found that of the patients who are on metformin, a lactate that was greater than 8.4 and a creatinine greater than 2.9 had a specificity of 99% for mala. So it was actually like very, very useful for me as like was seeing this patient. I was like, okay, she kind of fits like all of the parameters I'm looking for. Okay, so management. So if it was an acute overdose and the patient presented like within an hour, you could try activated charcoal if they were like alert and able to take it. If for some reason they were on extended release formulation, you could give activated charcoal up to like 4 hours. But for all the patients who are like chronically on metformin, you don't have that option. You can give them fluids and then pressors if they need it for persistent hypotension. And then the only other real like difference in management is to consider a bicarbonate drip if they have a persistent pH under 7.2 and an associated AKI. So that has the benefit primarily in decreasing their need ultimately to go on to dialysis, but it may also have a small associated mortality benefit in these patients. Okay, so our patient got started on pressors and a bicarb drip. We talked to renal and MICU. We repeated her blood gas like 2 hours later. She was still had a pretty high lactate and a pH of 7.2. So what do you guys think? Does she need dialysis? You got a yes? You got a no? I honestly don't remember. Um, So there's like two guidelines you can use to try to determine whether you think this patient needs dialysis for their mala. There's a poisoning work group recommendation on the left. So absolute indications being a lactate greater than 20, pH under 7, and then failure to improve. And failure to improve is defined as you've tried pressors, supportive care, and a bicarb drip for 2 to 4 hours, and they're still not getting better clinically. So I would say she met absolute criteria because she wasn't improving. There's some suggested criteria that I saw in Up to Date, which are like a little bit, softer, included shock, any shock requiring pressors, AKI, or like very severe CKD, liver failure, or confusion. Does anyone know what the benefit is in hemodialysis for these patients? It's actually like better for the correction of the metabolic acidosis. So it's like less in terms of there's less benefit in terms of like removing metformin and more in terms of correcting the metabolic acidosis. So Mickey was on board, Renal was on board. The patient initially refused dialysis. And it was like funny to me because she was like a former SICU nurse. So maybe that's why she was like hesitant. She's like, I feel fine. I'm not gonna die. I'm fine. And it was like very bizarre to me to be like, this is supposedly a very high mortality condition. If we don't dialyze you, I have no idea if you're gonna get better. Um, and then luckily MICU and her daughter actually convinced her. She got a trialysis, she got dialyzed, she was fine. She like was discharged, I think like a week later. Oops. So in summary, start a bicarb drip if you have a patient who has a pH under 7.2 and an AKI in suspected mala. Consider mala for all patients who are on metformin and have a high lactate, AKI, and or hypotension, and have a low threshold to involve MICU and nephrology on these patients. Okay. Overall summary, adrenal crisis is rare, but you will see a lot of relative adrenal insufficiency in your career. So consider these diagnoses when have your refractory shock patients or patients with persistent hypoglycemia or hyponatremia, decompensated hypothyroidism, hydrocortisone and IVT4 are very safe to give, involve endocrine in terms of deciding on any other treatment plans. And then mala, as we mentioned before. Okay, and that's it. These are my references.